Okay, so some of you may know me, some of you may not. I've worked in the organisation for 32 years, and for about 20 of those, I've managed outpatients and sort of the clinical admin services. So following the merger, I was originally from Worthing and I've taken over the teams from Brighton. So I manage the booking teams, both outpatients and admissions, the validation teams at both sites, ward clerks, receptionists, and medical secretaries on the Brighton site as well. So I've got a team of about 600. And one of the challenges that we were given, which is where the Access Transformation program was born, was about how we standardize and communicate with patients more effectively and efficiently. So hopefully you can see that. I put it into presenting mode earlier and it went a bit crazy. I've had a few network issues, but hopefully you can see that. I'm happy to share the slides afterwards. So when the program was born about 18 months ago, we were originally looking at the standardized route for referrals into the organisation because it was complex and multiple and took a lot of time for referrals to get into the system, into the correct system, having been triaged correctly. The programme since the beginning has actually expanded, as we would expect, into about 6 different work streams. And I'll briefly take you through those work streams and the results that we've had so far. And as I said, I'll stop at the end and ask if anyone's got questions or comments and we can discuss, and I'll move on to the next. So this was the original charter that I'd put there. So really we were just looking at how we manage referrals coming into the system in an efficient way. So I think I came to speak to you earlier on this year and we were talking about NetCall, which is our main method of communication within the outpatient team. So we do a number of things through that. So the first thing we deployed back in April was our waiting list validation. And that is simply a communication to patients once they've been on our waiting list for 12 weeks as a kind of a contact point to let them know that they are on our waiting list and we haven't forgotten about them, because 12 weeks is an awfully long time for patients to wait, but also to check whether their health requirements are still that they wish to be seen. Now, we deployed that back in April. Literally from the first week, we had a 90% response rate from patients telling us whether they wish to remain on our waiting list or not. And about 13% of patients tell us that they no longer need to be seen. And that might be because their symptoms have resolved. It might be because they've been seen in another healthcare setting, in community services or GP, or it may be that they've actually gone private for a consultation. So we contact around 4,000 patients a week through this method. We surface notifications through the NHS app. If a patient doesn't respond through that, we go back to an SMS text where they can log in and tell us. If they don't wish to communicate with us that way, we revert to letter that's got a QR code and it's also got a telephone number on it. So we're trying to think about all the ways that we can communicate with patients so that they can tell us what their health needs are. The next one is around appointment reminders. Obviously, as a trust, we're trying to be more productive and efficient and reduce the did not attends into our clinics. We have sent hundreds of thousands, and I've got the stats in a moment that I'll share with you. Our DNA rates in the services that use our reminder software have gone from 7% down to just under 4%. So it's really working. And we've now, we're investing time with the services to understand why they may not wish to have reminders on the certain appointments that because of the way clinics are set up or named, we might not want to send a reminder with that particular wording in. So we're looking at other ways of how we can communicate with patients. And then the third part of this work stream is our contact centre software. So when patients phone into the booking team to ask about appointments, we went live with that 3 weeks ago. Now, we're the first trust in the country to go live with this CX software that has natural language, and that means what we have is an assistant, but an automated virtual assistant who we've called Ava, and she actually speaks to the patients and the patients can speak back. And in the 3 weeks, we have more than halved our abandoned calls into the contact centre. Our average waiting time has gone from 20 minutes to answer a call down to less than 5 minutes. And we're diverting about 30% of the calls that we get into the contact centre that we can't manage within there. So we don't, for example, we don't book x-ray appointments and we don't book pathology appointments within that contact centre. But instead of a patient being diverted there, perhaps from switchboard or somebody else that doesn't quite know where to put a patient, they sit there for 20 minutes and then we tell them we can't help them. We do it within 2 minutes of them answering the call. We re-divert them to a service that can help them. It's kind of, we haven't stopped there. So although this was the output of the patient access transformation work stream, we're just starting a pilot with NHS England and Netcall to look at AI prediction for DNAs, which is really exciting. So we haven't seen an output yet. It's supposed to be delivered by March, and also clinic utilisation. If we get, I'm sure you'll appreciate, we get short notice clinics that are put on at late notice where we're trying to see patients that have been waiting a long time, and sometimes we can get 24, 48 hours notice. What happens there is we divert pretty much 100% of our workforce trying to fill that capacity so that we don't waste it. What Netcall has come up with is an automated solution that we can give the software a clinic and a list of patients, and the software will go and call those patients until a patient answers and says that they would like to accept that appointment, and then it gets put back to an agent within the contact centre. There's advanced steps that we can do about automatically booking, but at the moment capacity is in high demand, so we're keeping control of that. The other thing that we're just about to go live with is our web chat that will go on our web page. And we're really excited about that. That will literally, in real time, translate into any language that a patient types a query into, which is something that we haven't been able to do. And I think we'll be, the first trust to do that. So I can expand on that when we go live with that. We're just working that through at the moment with our comms team who is supporting us. I'll just move on to some of the stats and then I'll pause and I'll take any questions or comments from any of you. So the patient hub is the software that Netcall deploys, and that's where we send notifications out through. If a patient wants to respond to us via Netcall, they don't need to sign up to an app. They get a two-factor authentication. So you'll see that in the April to October, which is the latest figures that I've got, we've sent almost 2.4 million messages to patients, and that is about waiting list validation, and that is about upcoming appointments. We're also just starting surveys. So one of the surveys that we're starting is did not attend. So if a patient doesn't attend their appointment, we're sending them a survey to try and get some information. So it's, can you tell us what we could do differently? Was there a particular reason you didn't attend? Was it illness on the day? Did you forget about it? Was it childcare? Was it transport? That kind of thing, just to give us some information that we can perhaps improve how we communicate with patients. So you can see the breakdown of the different messages and the types of messages we're sending. Just moving on to the waiting list validation, that was the first project I spoke about, where we're trying to understand whether a patient still wants to be seen or not. Here we've got an 83% response rate. That's via Netcall. The other 7% comes via the NHS app that we contact patients through. And as you see, it's a vast number that we're able to do. This is we've fully automated this. So at the back end, we've got digital workers that process patient responses so we can keep our PAS systems up to date. So the responses, as I said, we've got 90% response rate, a 10% discharge, which is slightly lower than I quoted. This is because we contact patients every 12 weeks. So some patients who have been waiting for a long time for an appointment will have now been asked 2 or 3 times whether they wish to remain on the waiting list. But it's important for us to make sure that we have up-to-date and accurate waiting lists. The outpatient appointment management, so this is the reminders. So we've processed just under 500,000 appointments in the 6 months that's reported here, and again we get about 70% response rate via Patient Hub. And lastly, this was the DNA that I'm referencing. Actually, the non-messaging via NetCall, the higher 8.5, is slightly over and above what we see as a DNA rate. This is because we know we've got some clinics in there that need to be excluded that haven't been. So they're assessment clinics and things like that we wouldn't want to send reminders, and we don't manage in a typical outpatient clinic way. But you can see it's a significant difference where we've deployed messaging to remind patients about their appointments. So before I move on to the next one, I'm really happy to take any questions or comments or clarify anything from it for any of you. Stunned silence from everybody. That's a lot of information. I absolutely know that. Francis, I think you're first. Francis, you're on mute.
Thank you. That was really interesting, Donna, and you've obviously done an enormous amount of work. And I recognise, sorry about my voice, I've got a bug. I recognise a lot of what you're saying in experiences that I've had myself, you know, improvements and family members, etc. I've got 2, 3 sort of tiddly little questions. Do you want me to ask them, and then you answer that one, and then ask the next one? Because
however, yeah.
Forget. I mean, one is the first one is about when you phone around to validate. Do you have the figures about how many people have gone privately?
Yes, we have got that.
And what's are we talking about large figures or a high proportion of figures have gone people have gone privately, or is it, you know, balanced by people who no longer need help, you know, for whatever reason, either got worse or better?
So you know? I'll have to dig around. I haven't got it off the only one I've got off the top of my head, Francis, is of that 13% that tell us they no longer want to be seen. 50% of them, their symptoms have resolved and they no longer need to be seen.
And then well, that's good. Yeah.
And then and that's amazing for us, because it allows us to then open that conversation with our primary care colleagues to say, oh, are we doing things quite right? If patients are waiting and things are resolving on their own, have we got the pathway right? And it may be that it's absolutely appropriate, but it's just a discussion point that we can start to really understand how we can support patients, perhaps in a different way.
Well, that's good. That's good. The second area was about children's services. I assume that they're part of this, you know, sort of improved service improvement. Yeah, and I just wondered about pathology. Just a personal experience I had trying to book an appointment for a child for a blood test, and it's this AI thing, this AVA thing that you're talking about. I don't know whether I was dealing with AVA or whether I wasn't, whether it's there now, but I phoned up the number that I was given and I just went into a loop, and is just some reassurance that's not going to happen when AVA comes around. You know, I couldn't actually get through to anybody in the end anywhere.
Oh gosh.
And on anything, and so it's just because, you know, I just kept going round in a circle. You know, go to this number and everything.
Oh,
so will AVA deal with that?
Well, so I should have thought to get a little demo of AVA really for you, but I think I can talk enough for an hour without that, but we can certainly do that another time. the way that we've built Ava is that at any point a patient will always end up with a contact center person at the end, wherever, unless we can support them through self-service or something. And even so, for example, if a patient phones to say, I want to change my appointment, we will offer them an SMS or a message so that they can click the link and do it themselves. So self-serve, so not sit on the phone and wait for it. When we've offered that, a patient can say no, but even if they say yes, we will still check and say, did you need to speak to somebody about something else? And we've purposely built that. I suppose the thing I would say about this is that Ava only covers the central services that fall within my remit at the moment. So things like pathology, radiology, a lot of dietetics and things like that don't sit within the central booking team at the moment.
Okay.
And that's a different work stream that I'm going to talk about in a little bit, because
Okay.
there's a different work stream around, should we centralize everything? Is decentralized working, what's the best way to do? So that was part of the patient access transformation. But I guess the important thing for us was to try and deploy it as quickly as possible, because we knew we were getting so many patients who were dissatisfied, waiting a long time, hanging up the phone, etc., that we wanted to get that bit done. But because what we've done so far has been so successful, part of the patient access transformation is how can we bring in the rest of the trust so that they also benefit from this in the same way.
Okay, that's, I don't want to hog the tongue of just one
No,
quick
that's
one. It is, I hope it's probably not quick, it never is when you say that, is it? It's about, will this dispense with letters going out with using the Royal Mail, which often delivers the appointment after the appointment time?
So yes. So it's quite a complex landscape that we're working with IT on. So any appointment gets notified, but as I'm sure you all know, we also have Patient Knows Best, which also delivers notifications. And what we're trying to do is find the balance between who's sending what, because we don't want to overload patients with everything, but also we want to make sure that it's meaningful and the timing's correct, etc., etc. So there's a big piece of work that we're working with IT on about how we deliver things. I mean, the end goal for us is to get everything through the NHS app so patients can go in and have a look at everything, how long they've got to wait, what appointments they've got, any changes, etc., etc. Certainly any cancellations, any appointment notifications go out digitally. In the central team, our letters go out via Synertec, which is our hybrid mail solution for the trust. So if a patient doesn't look at their letter digitally, then it reverts to post via Synertec. So that's already in place. So there's a big project that there's a business case that's just gone through that IT will be picking up to look at that, and the letters that aren't currently digital. So there's a whole plan, because there's obviously financial savings in that as well as kind of efficiency and better communication with patients. So that is, I think the business case went through last week or the week before. So I would expect to see significant improvement in the volumes of digital letters that we deliver to patients.
Okay, thanks, Donna. I think there's an appreciable difference in since you've been doing your work. So thank you.
Oh, thank you, Alison.
Thank you, and yeah, thanks for the presentation. It's interesting that there's so much going on. I agree with Frances about some loops that you can get stuck in, and now I've got your name, I know who to go to if I get anything, so that's all right. But couple of comments. One about, and I agree, it's going to be preferable to have people understanding exactly how they get their information and how they don't. And it just occurred to me, like when you log onto your credit card and it says, do you have paper or not, that, and you can see at a glance what you're getting, because I think there's I don't actually know what I get. I get some text, I get some emails, some say I've got a notification, and it's quite confusing which bit I'm looking at as to which. So I think the communication to people, so they understand how they're getting something and it stops the duplication, will be amazing. The only query I was going to say is about cancellations, and when you're talking about the Ava, if you say you want to cancel something, can that deal with it? Because my daughter, just as a point, tried to cancel a skincare appointment because she had a cyst that had just disappeared, but couldn't get through, left a message, but we still got the nasty letter at the end to say you didn't come. So it was just, I actually think that doctor surgeries are actually dreadful at that as well, because you've got a queue for half an hour to tell them you don't want the appointment. So it's anything that you could just click something or go to a separate option to cancel an appointment would just be better for everyone.
Yeah, I think it's really difficult because we've started with a really complex landscape of some areas I manage the booking of, some areas I don't manage the booking of. Dermatology actually doesn't sit on the PAS system that we use. It sits on System 1, which is a primary care system. So it's a work in progress. It's not perfect. We're trying to improve it where we can, and then almost department by department we'll be bringing everything in. We know that it isn't perfect and it is complex,
but it's on the radar. So
and we spent a whole afternoon with IT looking at exactly that. Who sends out notifications? What are they about? How frequently do they go? Are we sending it multiple times for the same thing? So we're truly trying to unpick it, but it isn't an overnight solution because we have the complexities of SMS and email and NHS app, etc., etc. It's making sure that we're confident that we're not going to lose anything by turning anything off.
So and it's difficult, like you say, with patients knows best, because we've got that as well, but that system isn't on that. So it's lots of different things aren't on the same ones, and I think this goes back to the communication, so people can easily find out what information they get and how.
Absolutely. So we're definitely looking at that, but it's not quick and it's not easy, but it's definitely a priority for us to resolve. Doug.
Oh. Well, if this is all true, it's a dramatic change. Speaking personally, last year in September, I went to my doctor for a hernia repair. He said, well, I won't send you to UHS Sussex because you're absolutely hopeless at handling referrals. He said you probably wouldn't even get on the list for 6 months. So he sent me to East Surrey. I never heard anything from them until just recently when they said, would you like to go to Ramsey Health? And I was up there last Saturday. But I mean, if this system works, it's a fantastic difference.
We've got another, so well, I'll talk about referrals is my next work stream that I'm going to talk about. And I promise you the results I'm showing you are absolutely true. We're still learning. Some of it's quite new. So Ava is only 3 weeks old and we're gradually refining kind of what we do and improving it. We'll be looking for feedback from patients. So with Ava, at the end of a call, we can actually, there's a little survey that we can survey patients to say, did you get what you wanted, and ask about the agent that they spoke to, and we'll be deploying that once we're a bit more than 3 weeks in. I feel a bit nervous about setting a survey when we're still refining the system, because we're a massive hospital with so many sites, many services. So bringing that all in, but we're really excited, and actually we won a Health Tech News Award for this back in October, and we've just been shortlisted for an HSJ Patient Experience and Engagement Award. So we found that out on Monday, and we'll find out whether we are finalist or winner in March at the award ceremony. But we're so proud of what we've done so far.
Are people told that they will be speaking to a virtual assistant?
she does say that she is a virtual assistant. She does say, she says, I'm Ava, I'm your virtual assistant. I'm here to help direct your call. I can help you best if you speak to me in short sentences. So people know. It actually throws them off a little bit because she does sound quite human, and so patients are going they've almost forgotten what they've got to say. So we're going to be doing a bit more work on what works best, perhaps testing it with different groups of patients as well. But she does say she is a robot. I can't see. Oh, Colin.
Yeah, thank you. Oh. Thank you. Yeah, just a thought. I mean, fantastic that you've been shortlisted for these awards and so on. Are the comms team picking this up? And because, you know, we have so much negative publicity comes out about the trust, we ought to be blowing our trumpets about this, surely.
Well, I'm blowing the trumpet everywhere, and comms are aware. George did us a lovely message in his communications this week, but I'm not sure if we're doing anything external yet. And I would love to see some sort of social campaign on the work we're doing, because I think that also helps us with patients. So if they do phone in and they get AVA, it's not a shock, because this is very different from how we've operated up until 3 weeks ago. And I think patients are a bit taken aback that they're speaking to a virtual assistant. So, and I need to think about how we can do that, but certainly we're working very closely with comms, and we need to. I think now we're live, because we've delivered this on top of our day job. So I've got 600 staff and a recovery program, etc., etc. We've had no additional resource to help us deploy all of this. So literally we've been running at pace to deliver a lot of the work streams that I'm going to describe to you. And I think now the CX AVA's gone live, we're kind of at a breathing, well, before we get into winter pressures of January and all the cancellations that I'm sure we will see as we do every year, we've kind of got that moment to sit and think, okay, what does the next 6 to 12 months look like? And actually, how can we celebrate our success? Because I think you're absolutely right, Colin. I think there's a lot of bad press around our organisation out there, and we could really tell a good news story, but also encourage patients to sign up to the NHS app, because that's one of the things that will help patients not get multiple communications through email and SMS, etc., etc. If we can, if the ultimate goal is to deliver everything through the NHS app like GP surgeries do, if you have the app, you can often see your consultations with a GP, your medications, you can order prescriptions, etc., etc. We want to serve the population, or give the option for our patients in that way for hospital services too. I can't see any more hands up. Are we happy for me to move on to the next, or is there anything else? Yep, thumbs up. Thank you. I'm just going to move you over. So, so the next work stream is about referrals. So if you remember at the beginning, the aim was to manage referrals and to get them moving around the system and uploaded in a timely way, effectively, accurately. So this ERS program work stream. So ERS is the National Electronic Referral System that is used by every primary care and other agencies to send in referrals to an acute trust, or to request advice and guidance from a trust prior to a. And what it does is, so the program that we've set up, because we had 2 different systems between legacy East and West hospitals. So the West would get a referral in. They would upload it manually to a different system called DocMan, which would send that referral to one of our clinicians, who would then triage it, prioritise it, put any comments on, and instructions prior to a referral. So perhaps an X-ray on arrival, or audiology on arrival, or something like that, so we could book multiple appointments for that patient. Then it went back. Then it had to be taken out of this system and uploaded into our PAS system, ready to be booked, which is not ideal. And Brighton followed more or less the same process, but using it, not DocMan, using a different system. So we needed to simplify this. It's absolutely crazy. We're paying for an additional system. It's adding days, if not weeks, to referrals coming into the trust. So what we have done is our clinicians, we're working around our clinicians. I think we're about 60% on using this now, where they actually go into ERS, into the national system, and triage the referrals there directly within that system. Then using robotic process automation, so again, digital workers, that recognises when a clinician's been in and added their comments, picks it up from ERS and updates it into our PAS system, ready for our bookers to book. And that happens instantly, real time. When a clinician goes in, as soon as they've done it, the robot picks it up and puts it in, so it's ready for booking. So we've reduced that referral process by days, weeks, hours. In addition, it because it uploads it automatically, our data quality has improved, the administrative burden. So when we put together the business case for a robotic process automation, we estimated that we would reduce our administrative whole time equivalents by 10, and we have done that and exceeded that, and we have no delays in referrals being uploaded. We have deployed advice and guidance, so our advice and guidance responses back to GPs within the required 48 hours has increased and improved. So this is another work stream that we're really, really proud of the results. So I've just pulled a few slides from our patient access transformation steering group just to show you what we report back in there. So you'll see that we're split into the 4 divisions, and the yellow and red are the legacy East and legacy West of where we're up to. So you can see medicine in the over at Princess Royal in Royal Sussex County, they are 100%, their clinicians go into the electronic referral system and triage within there. There are a few complications with some other services. So just on my next slide, let me move along. On the next one, we can see the services in green are the ones that are live. The services in amber are the ones that are going live. So pain and actually the general surgery at the Worthing and St Richard's are going live on the 16th. And then there are some others that have got a few complications or a few things that we just need to work through before we go live, because we don't want to miss any referrals, and we don't want to delay referrals in any way. And the specialties that need to be confirmed. So ophthalmology, because a lot of our referrals come from optometrists rather than GPs, it means we need to think about it in a slightly different way. So it's not that we're not getting engagement, it just means we need to do something slightly different. So again, we're going with the majority because it's making such a difference. The referrals are in there, they're ready to book. We can see the size of the waiting list. We can see what capacity we need to put on for patients, and we're taking our time over the last few. But this is picked up in the divisional SDR meeting. So it's a target for divisions to help us deliver this, because obviously we need participation from clinicians in all areas. So just an update there. So again, I'm happy to take any comments, questions about what's happening there. It's probably a bit less interesting than the Thomas, you saved me. As I said, probably a bit less interesting than the patient comms stuff.
Hi Donna, very well done for both projects. It's absolutely amazing, the transformation. It's like clearly see the entering to the 21st century with the use of the robotic and AI, which I love to see. Just a quick question: is them on the second part? Is them cancer services included in that project as well?
So at the moment it isn't, but it is We can do it. So we're working with Dom and Richard because they wanted a slight tweak so that they're. Let me start again. The referrals are being triaged within ERS. So the first part of the process is on the back end automation. Cancer services want a slightly different solution, which means a tweak to the actual automation. And we're just working through what that looks like, because obviously we then need to give it to the developers and go through testing. So there's a bit of a question about, do we really need to do it, or is it a slightly different manual process? It's about duplicate referrals, or do we actually need a slightly different solution on the automation back end? But if we could theoretically turn it on with a bit of a manual adjustment, but certainly the front end is the same.
I understand. The only question, because obviously they are not on the timeline. So I was thinking that there is probably something which they need a little bit special approach because of their being a little bit special as well in what they do. But yeah, absolutely. Thank you very much.
Francis.
Yeah, it's about advice and guidance, Donna. It's really good that you're able to, you've got a system in place to turn it around quickly. This might not be a question for you, but are the figures for people requesting advice and guidance and, sort of reducing people having to sort of have an appointment, if you like, because they can be managed in general practice? Is that in your domain, or is that information somewhere else in the system?
So I can access it. I don't collect it. There's somebody at the ICB that collects that information. Certainly our requests for advice and guidance are increasing, which would say that GPs are beginning to gain confidence that we will respond in a timely way. And it's partly because of the process. So for example, in the Worthing Chichester practices, the GPs don't use ERS, so they commission an interim service who takes the referrals from them and they upload it into ERS, and then we would take it. I know, honestly. So when we went back with an advice and guidance response, it goes back to that team who then send it back. So the whole thing is a protracted process, but because now we can automatically do that, we've almost halved the time. So there's a confidence there, but GPs in that area still don't do it directly. The Brighton GPs do access directly into ERS. So that's always historically had a much higher compliance rate, but we're seeing significant improvement in the West as well. But the other thing about an advice and guidance request is we can actually convert it into a referral as well. So if we get something that's asking for advice, but the clinician is concerned about that, we can automatically convert it into a referral and push it through for an appointment, which is
so it doesn't have to go back to the GP and then be
no,
for those
it doesn't.
Who don't know, with advice and guidance, I mean, it's a facility, for GPs to be able, if they're not sure about something, to check out with the consultants rather than do a referral. So it's a really good service, and but it's historically hasn't been all that well used in different areas, which you're indicating. So it sounds like if you can get the system really good for the GPs, because GPs are more likely to use it. So I suppose really your audience there, in terms of there was some conversation before about promoting all the improvements you're making with the public, but there it's with the GPs, isn't it, that they need to know that actually it's much easier now for them to be able to get this information back in a timely manner. And I wonder whether or not comms help you with that sort of communications as well as to the broader public.
Yeah, absolutely. And we're working closely with our ICB colleagues as well, because as Doug said earlier, he was referred to a provider and then was offered an alternative provider. One of the other areas that falls under my management is our elective care coordination centre, and I'm not sure if any of you have heard of that, but essentially because we have a high number of long waiting patients, we've developed with our ICB and our other providers, both independent and NHS providers, our longest waiting patients, we are offering them alternative to be seen and treated more quickly, and we're working with 20 other providers locally and not so locally, so into Kent, Surrey, London, Hampshire. We're basically giving patients the option of whether they would like to be treated sooner somewhere else if they're able to travel. So we started in April, and since then we've offered alternative providers to about 16,000 patients to try and get them seen more quickly. So we're doing a lot of work with GPs and the ICB and other providers trying to promote the work we're doing. But I think you're absolutely right, Francis. We're not shouting about what we're doing at all in the way that we should be.
Anyway, sorry, it's just that GPs are really important, as other people have said here,
No, absolutely.
about access, and if they're not sure what the system is in the hospital, then they tend to try it once. No GPs here. I'll try it once, and if it doesn't work, then I won't try again. You know,
you're right.
Just
You're
it didn't
absolutely
work
right.
last time, sort of thing.
Yeah.
Not realise that you've actually improved it a lot. Thank you.
I mean, the hope is, as I said, with the waiting list validation and patients that are telling us that their symptoms have gone away, is that we can start having those conversations with our primary care colleagues and other providers as well, so that we can really start that communication, so that we can properly deliver change for patients at the front end, doing the right thing at the right time for them. So I'm really excited that this is really just the beginning of putting kind of almost the hidden bits in that nobody can really see, but we'll suddenly start to feel the differences. It's a bit more slick, but the magic's yet to come, really, once those basic processes are in place.
It seems like you're picking up evidence that you can have a proper conversation with general practitioners, rather than just
theory,
anecdotes and this, that, and the other. You've got some evidence, which I think is probably very helpful.
Which is why I'm so pleased to be back here, because when I came to speak to you last time, it was like, we're going to do this and we think this is going to happen, but actually it really has happened. So I'm so happy to be able to come and tell you that we've realised some of our ambition from a few months ago. I can't see any more hands. Happy to move on. I think we're going to run out of time, aren't we? Right, I'm going to move on to the next one. So this one is around waiting list validation, and this one was added in a bit later because all of the work that we have been doing, so with the waiting list validation, with the reduction of DNA work that we're doing, with the elective care coordination centre work that we're moving patients around, it's absolutely vital that we maintain accurate and up-to-date waiting lists. So we added this too because it just felt that the Patient Access Transformation Programme was the right place for this work to sit. And also NHS England brought in the operational planning guidance that we needed to make sure that patients are validated every 12 weeks, as I demonstrated earlier. But there's both RADAR and LUNA compliance, and we've managed over the last, again, six to 8 months to improve our compliance. So we've actually achieved just over 72%, back from 60 in September, and we rank higher than both NHS England and the whole of our Southeast region as an organisation. And LUNA compliance, so that's data quality. So the increase to 2.8 is actually increased performance rather than an increase in percentage, and we're now ranked to the sixth highest trust out of the 135 locally. And the IRIS training, so that's our internal training, we're putting anybody that validates patient pathways, and that is to progress patients to make sure that they're moving along and they're getting all the appointments that they need to see, follows a structured framework so that we're not losing patients, we're not misrecording anything, and we're just making sure that whether staff that are centrally managed or managed within the divisions, we've got a standardized approach to everything there. And again, I've just got a couple of charts to show you. So we are that's quite small, I'm sure, on your screen. We are the black line. So That's 75% is the amber and 90% is where we would like to be. And you can see we hover just there. This purple line here is NHS England and the light blue is the South East region. So we're very proud to be one of the highest performers in the area. And then this other one, so this is the lunar compliance. So you'll see down here it goes the other way. The green is the 2% and we're literally just above it. And we know that that isn't because of our performance. There's actually a bit of a data anomaly in there that we're trying to resolve with NHS England, which will take us to the green position on there. So I'll stop just quickly if there's any comments, but it's probably a bit less interesting than this. Just one more project really that I'd like to talk about in a bit of detail if we're happy to move on. But I wanted to put that in because what that shows is the work we're doing is actually properly making a difference to our waiting lists and to our performance as an organisation. So the last one that I want to talk about is our booking model redesign work stream, and I think since the deployment of some of the other work streams that I spoke about earlier, this is becoming more and more important, where we're trying to bring together the booking team so that we can utilise the capacity across all of our 7 hospitals rather than working in that siloed, this team books these clinics and this team books these clinics. What we're doing, and it's fairly ambitious, is to look at every single clinic that we have live at the moment and standardise what we call it, what appointments go into it, and we'll follow kind of GIRFT guidelines, so getting it right first time. So the proper I can't think of the word I want, but you know, the what we should be following, because we know that within even specialties we don't have standardized templates across specialties, and subspecialties do require different templates, but it's an opportunity for us to, do we have enough 2-week rule or urgent suspected cancer capacity? Do we have the right balance of new to follow-ups within that? Are we using PIFU in a way we would want to? Have we got reminders, surveys and validations attached to every clinic? Do we have we got the right letters and information that goes out to patients? Have we got that standardized naming so that we can bring a team together? So we've got a single, for example, gynecology booking team that can book any clinic across any site, and therefore we can start to give equity in waiting times, not based on postcode or anything else. We can have that conversation with patients to say, oh, I can see your local hospital's this, the waiting time's there, but if you could travel to there, we could get you in a bit quicker. And I think depending on patients' personal circumstances, they might be able to take up something a bit further afield, but there'll be some patients that rely on public transport and don't mind waiting that bit longer to stay more local. But at least it gives us that opportunity to have that dialogue with a patient. Now, I've explained that in 2 minutes flat and made it sound really easy, but trust me, it is not. There we have got thousands. I think we've got 8,000 clinics or something like that on our books at the moment. So this is not a small task, but the benefit that we will get from doing this will take us again into that next step. We know that we've got clinics that we haven't used for donkey's years, and our performance, our productivity and efficiency is being measured against those clinics that we know we don't even use anymore. So it's a bit of a housekeeping exercise, but hopefully will kind of support us in so many ways outside of what we're looking to do. So I'll stop there because that was a lot of information in a few minutes as well. I appreciate. So if anyone's got questions or comments, then I'm really happy to take them. If you don't know what I'm talking about, I'm happy to explain it again. Francis, you're on mute.
I'm sorry, it's me again.
No, I'm welcoming it, Francis. You must be bored of listening to me by now.
No, I just think it's one of the most important things around. and it's, you know, as you know, governors, whether we're staff or whether we're public governors, I mean, you know, things like improving the waiting times, both
Yeah.
improving the length of them, but also the experience whilst you're waiting, and you know how you communicated is one of the things that you hear gripes all the time.
Yeah.
So all of this is music to my ears anyway. Anything that can bring improvement. I totally understand what you're talking about, booking redesign. I mean, there must be all sorts of custom and practices and cultural issues, and we've always done it like this, and etc. that are going on. So I appreciate it's a people issue as well as a forms and a systems issue. I wonder whether you'd say something about PIFU, which is the patient initiated follow-up,
follow-up. Yeah.
where people don't have a given follow-up appointment after a procedure, but they can actually initiate a follow-up if they feel as if something, they need some advice or help, or something's going wrong, etc. How that's actually working.
So in some services, it works amazingly well. So in physiotherapy, for example, there's a very high uptake of PIFU. In other services, it's less successful. I think part of it is the capacity for divisions to actually engage with it in a way that we'd want to. So I've got an assigned project person that's working with the divisions, because excuse me, it's in theory, and we've been working with SOS appointments for many years, but there are lots of rules around PIFU, that it has to be a clinical conversation between a clinician and a patient before they can be put onto a PIFU pathway, and there has to be information shared with the patient in that consultation, so that they're absolutely clear that they will not be getting a follow-up, and it's up to them to initiate it. So it's quite a cultural change as well. So in areas, so in the medical in the medicine side of things, where you've got chronic conditions where patients are sort of frequent flyers for that, I think it really works well, in that we know we're going to see you and we'll keep seeing you, but you can initiate. So for example, IBD, so irritable bowel disease, a patient wants to see us when they've got a flare up, not necessarily in 3 months' time when we've planned their follow up. So in areas like that, it can work really well. I'm actually just looking at, so Netcall, my solution to everything, actually has a PIFU module, and I'm going to try and get a demo of that to see whether that would support our divisions and our clinicians to making it easier for them, because then a patient can just go into Patient Hub and request that appointment, rather than going through you've got to go through here. And some services want us to book appointments if a patient initiates it. Some want to do some sort of triage, either with a nurse or a secretary or administrator or something like that, before we book an appointment. So we don't have a standardized approach. We're trying to sort of tailor it to the service at the moment. And I think, to be honest, although we do it, and I think we've got about 3%, I think the target for PIFU is about 5%, and I think we come in at around 3% from memory. I think we need to go back to the drawing board, because we can simplify and improve that, because it is the best. It's a good solution for some patients.
Yeah. Okay. I mean, sorry for those people who might not be so interested. It is important though, because it makes patients can have a timely appointment, and avoid unnecessary appointments, you know, for everybody, sort of thing. And what you're saying, the latter bit, echoes some of the feedback I've been getting, that it seems more complicated than it should be.
Yes.
And so anything that you can do in your deliberations, I think, would be quite useful. And again, it would be a productivity and efficiency saving as well, wouldn't it, if you could actually get more of these appointments rather than
absolutely,
etc.
And I think something like having Netcall as that vehicle to do it gives us a standardized approach and something that patients will start to trust. As we validate and send notifications, they'll have confidence in it, and we'll have a complete record of everybody that's contacted and can then do it. Whereas at the moment it's a bit piecemeal, kind of depending on how a service wants to work and what staff they've got in and whether they want to triage. So I think we've made it complicated for ourselves. So I think you're absolutely right, Francis. It's time for us to take stock and go, how can we deliver this in a way that will help us? Doug.
I was just wondering about how loading on the emergency department might affect it.
Sorry.
Well, I mean, at the moment, you know, as people go from the emergency department, they take up the beds. How does this affect your booking system?
Okay, so it does affect us. So everything I've described to you today is around outpatients. So Netcall does have an admitted module for theatre bookings and that, but I'm going to need to write a business case for us to procure that, and then we can offer the same service. But essentially, emergency department pressure or not being able to discharge patients from beds because there's not places for patients to go to basically means we cancel surgeries if we haven't got a bed to put a patient into when they've had their surgery, then we have to cancel. And in January and February, with winter pressures and high demand in A&E, we know that will happen to us. So it's a lot of rebooking, a lot of disappointed patients, a lot of stress on our booking teams that are having those conversations, sometimes more than once with a patient. And it's a really tricky, there's a lot of people that work to support us to try and get as many patients in. But yes, it's difficult. Ben, I'm not sure. We've got 2 minutes. I was going to talk about e-pre-assessment, but to be honest, it hasn't really. There's a business case going in January, so there's not a lot to talk about. So I'm happy to finish there and take any final thoughts or questions from anyone here before we go. But just before I do, I'd like to say thank you so much for inviting me back. I love talking about everything we're doing, particularly as it feels like we really are finally making that difference to patients. And I'm happy to come back at any time to update you or to talk about specific bits and pieces of it as you want me to. Alison.
Thanks. I just wanted to touch base. It's probably not your remit, but on digital literacy, is there anywhere that we can signpost people to who may have issues and not be able to, where they can get assistance?
So we are. I mean, that's one of the things that I'd really welcome help on as well, Alison. I mean, obviously we're trying to oh gosh, I don't know what's happened there. I don't know what's happened there. Am I sharing? Is somebody else sharing? Is that you sharing, Ben? Have you wiped me off? I was like, I don't recognise that screen.
Sorry, John. I was trying to clean up the screen and failed.
No, that's fine. That's fine. Because obviously we know, so we're trying to deliver digitally. For those that don't engage, we're reverting to letter and we've got telephone assistance. But obviously we're trying to do as much as we can, but we know there is more to be done. And I would welcome any thoughts or help that anyone's got on that, because that is the next thing for us to do. So, I mean, we've deployed everything to catch the majority of the population, to give us time to think about the rest. So language is the next thing that we're looking at, obviously, with our web-based chat, because that will help us. But anything else that we can do, we'd be really interested to hear it.
Yeah, I'm not sure whether you work with the LCNs or not regarding that type of thing, because they have obviously footprints into areas of deprivation, and local things. But I would also say that the GP surgery, if they're not engaging with their GP digitally, then there could be a barrier there, and that would be the first port of call. But
so we're doing that kind of through the ICB is kind of helping us, because obviously they've got the same requirements that we have, so we're trying to do it in a joined up way.
Thanks.
Sorry, Ben, I've run over by a minute, 2 minutes now.
Sorry, no, you're perfectly fine. Thank you so much for such an informative talk. I can see Alison had a hand up, and I don't want to cut her off. A few of us will need to go to a meeting in a little while about around patient experience. It's fantastically helpful to have these sort of briefings for the governors, but the governors have another committee around the patient experience, and patients who are waiting, this is a significant part for them. So if there are elements like the prep sort of thing that you haven't had an opportunity to present here, if there's anything that we can bring through, I'm sure Maria and Fran, who co-chair that committee, would be grateful to receive it when it's ready and to take it through to that meeting. But sorry, I've cut across Alison just in case there was anything first.
I think Alison's gone.
No problem. Well, as I say, we are a little bit over time, but thank you so much, Donna, for going through all that. Other governors will be able to watch this back, and they may be in touch with you with any questions that come to mind.
Happy to answer anything that anyone's got afterwards, or if you've got any ideas, I'm really happy to hear them, so that we can further improve. But thank you so much for inviting me. I've enjoyed it. Thank you.
Thank you, Donna. That was brilliant.
Thank you. Bye. Bye, everyone.
Day.